Afternoon to you who are in Oxford, and good morning to you who are in Boston. It's a great pleasure to welcome you at this mini symposium of the Harvard Oxford program in epidemiology, the HOPE program. This is our first completely remote or Zoom symposium. And I think most of you will have seen the program, but I will very briefly tell you what you're going to expect. My name is Bert Hoffman. I'm the chair of the Department of Epidemiology of the Harvard Chan School of Public Health. And I'm your moderator for this session, which will take a total of 1.5 hours. First, we will hear on this topic of COVID testing, rapid COVID-19 testing, Dr. Michael Mina, who is assistant professor at our department in Boston. And he will give a talk to be discussed by Dr. David Hunter. I will introduce David later. After that, that pair will have a brief opportunity to ask questions and have make comments. And then we'll have our second session, which will start with a presentation of Dr. Tim Pito of Oxford, and he will be discussed by Dr. Mark Lipschitz of Boston. So with that, Dr. Michael Mina, please, I introduced you already as assistant professor in our Department of Epidemiology. You came in the right time, just about half a year before the pandemic started, and you are already a household name, not only in our department, but in the US. I give you the floor to speak about COVID-19 testing, where science, policy, and regulation collide. Dr. Michael Mina.
Well, thank you. Thanks, everyone. I'm honored to be able to speak at this, and I hope that it leads to many new collaborations between our departments and schools. So I want to talk a bit about COVID-19 testing, and in this case, I want to essentially the goal for this talk is to try to describe a type of testing which I think can help us suppress infection and do a much better job at controlling pandemics like the one that we are currently in, but also in the future, and hope to elucidate some of the problems that have plagued our ability to actually act effectively when it comes to testing from a regulatory landscape. And not just in the United States, although it is somewhat US focused, but these issues that I'll raise have plagued policy decisions in countries everywhere. So testing is traditionally medical. Most people who get a test that takes something biological out of them, evaluates some molecule in some way, is almost always used for medical work. There's very little regulatory landscape or even sort of language in many countries around a different type of testing for public health. So our testing that we have seen since the beginning of this pandemic has been largely the qPCR test for the virus. This is a test that will detect the viral RNA, usually from the nasopharynx, sometimes the saliva, sometimes the front of the nose. But it is almost always all of our language, our laws, our legal structure, and our regulatory focus is with the consideration of a test as a medical test for personal health. But in the midst of a pandemic, perhaps testing and focusing on tests as useful only for medicine ultimately misses the forest for the trees. We have thus far made all of our policies surrounding how to get people tested, especially here in the United States. I think you'll hear from Dr. Pito afterwards that the UK has been much more aggressive to move towards public health testing, but certainly in the United States, we have almost zero ability to think about a test as a population tool. And so we could have surveillance testing, which is could be asymptomatic individuals off the street, could be wastewater, could be surfaces. There's lots of different modalities. And the important thing is that the attributes needed for population health testing versus personal and medical testing are wholly distinct, not entirely distinct, but they are quite distinct. For screening is a different type of approach that, while it's formally regulated in the personal medical diagnostic space, is a different type of screening that's not just screening along the diagnostic pathway, but that could really focus on how to mitigate spread at the community level. That could be entrance screening, which is as it sounds. You test before you walk into a place like a school or a restaurant or a theater, and with the expectation that on the other side of that door, on the other side of that test, there is a lower frequency of people with the infection because they've been tested out. And so we think of that as a red light test, or do not enter if positive, but if negative, continue to do everything else as you otherwise would. And then there's public health testing, which is what I'm going to talk about a bit, which if it can be performed with frequency, and if results can be given back quickly, you could actually use testing to decrease spread of an infection without necessarily having contact tracing in place. And it can actually become one of the interventions by empowering people with knowledge that they are infected to help them be able to stay at home, not go to work, not go to school, not go to church or their parents' house when infected, and hopefully sever that transmission chain. So for clinical use, we have we focus on sensitivity. This is the FDA's primary focus. And there is essentially no focus at the FDA on the cost of testing or the frequency with which a test can be provided, nor the speed that it takes to get a test back. These metrics don't exist in the FDA framework to think about the test. For example, you could have an electron microscope that does an extremely good job at detecting a virus. It could maybe be used on one person a month, but that would be an authorized test. Sensitivity is the only thing, along with specificity, of course, that the FDA really focuses on. But is that the right approach during a pandemic? While sensitivity might be essential from a physician perspective, if I have a patient in front of me and I need to let that patient know whether their symptoms are due to COVID, sure, I want the best sensitive test I can get. But if I'm a governor of a state or a president of a country or prime minister, and I have to deal with the population spread of a pathogen, maybe sensitivity isn't the most. Maybe I should be focusing on the speed of results or the frequency at which tests and scale at which they can be brought out. And is it okay if to do so, you have to sacrifice sensitivity? Physicians would say no, and they have very loudly, but I hope this shows why that's not necessarily right. And the important piece is that these tests, there are tests that exist today, which are now being rolled out in the UK quite frequently, and in some other countries, but in the US, they still remain extraordinarily limited. These are rapid antigen tests, although now we're starting to see a whole new class of rapid tests that are actually PCR-like tests that look for the RNA. But rapid antigen tests essentially look directly for the virus. There's no amplification step, but they work just like a pregnancy test. I have them in my hands here. These are some rapid antigen tests. They're very simple. They can be made for pennies each, essentially. And if you get 2 lines, you're positive. If you get 1 line, you're negative. You take a swab, you put the swab in solution, and you put a test into that solution or a few drops onto the test. So these tests do exist, but they don't have an amplification step. You can see there's no machine here. So unlike PCR, which can take just a few molecules of RNA and can blow it up into millions so that it can be detected by an instrument, with an antigen, with a rapid antigen test, the sensitivity is necessarily going to be considerably lower at the molecular level, the analytical sensitivity. But is that what we need to focus on, or is it better to focus on the sensitivity to detect infectious people in the community? And these are 2 different types of sensitivity. One is sensitivity to actually catch molecules, but one is sensitivity to have enough testing that you catch infectious people. And so we've been attempting to explore this through both different thought experiments, but also some mathematical modeling. So to understand why it might not be so incredibly important to have the absolute most analytically sensitive test, we can look at what the viral kinetics do inside of a person. So when we look inside of an individual and we look at the growth of the virus, neither test will be positive during what we call an incubation period when the virus is just getting going. So somebody gets exposed for the next few days, neither test is positive, PCR nor antigen. But eventually the virus will get to a high enough level so that a swab in the nose will be able to detect you as positive on a PCR test. And that might be at around 1,000 RNA copies per milliliter. An antigen test, like this paper strip test that I have in my hand, might not turn positive until 100,000 or 1 million viral copies, RNA copies per milliliter. So a lot of people would say, you'd intuit that that's too much of a difference. You wouldn't want a test that has a limit of detection only of 100,000 or 1 million when other tests exist that have a limit of detection of 1,000. But by the point in time when the PCR test turns positive, the viral replication is fast. This is exponential growth of the virus inside the host. And so within a matter of hours, usually less than a day, even the test with a limit of detection that's 100 or 1,000 times less sensitive will begin to turn positive. And so, and that's essentially one of these antigen tests. So really the differential between the two tests is on the order of hours, maybe a day and a half in some individuals. But by the time somebody is transmitting, both of the tests are very positive. We normally show viral loads on a cycle threshold scale. What I'm showing here is a cycle threshold scale, which is also a log scale. And so the actual time that people are positive gets exaggerated. Over 99% of all of the virus during an infection occurs over just a few day period of time. But then the PCR test will stay positive for a very long time, on average around 20 days, maybe slightly more. So if you have a PCR test that's positive for 20 days, that's not necessarily a detection of infectiousness. So it might be a very good test for clinical use, because if I'm a physician and I have a patient who comes to me at day 15 and says, Doc, I want to know, am I sick because of COVID? I've had a stomach ache for a week and a half. I want to be able to give that information back to the patient and say, well, actually, we were able to do a PCR test and found that, yes, you have viral RNA in you. But if I'm a public health practitioner, my whole goal is to find people who are currently infectious or pre-infectious and isolate them so that they do not go on and spread. I don't want to look back necessarily and ask who was infectious last week or 2 weeks ago. Just to put, I'm sure that most people on this call or on this meeting are familiar with log scales, but I do like to show this. This is how we normally show viral loads in papers. We have CT thresholds, and we show that the viral load goes up and goes down, just like I just showed. But if we convert this to a linear scale, it looks like this. These two curves are identical. One is just one is a linear scale, one's a log scale. And so this is why I say on the previous slide that 99% of the viral load occurs in just a few day period of time, and the rest is very, very low viral load relative to peak. And so a vast majority of the transmission likely happens during a 3, 4, 5 day period of time when somebody's infected. And in the rest of the time, you are probably at low likelihood of infecting others, or you don't have any live virus left in you to infect, and it's no longer culturable. So in order to create the graph on the top, for those who might not be familiar with log scales, we're zooming in about 1 million times compared to the linear scale there to be able to see that long tail of PCR positivity. And so this is, I point this out because this long tail PCR positivity has been confused over and over and over throughout this pandemic as important to catch for testing. And again, maybe for a physician it might be, but for a public health official, if you can just catch the period of transmissibility, then that might be much better. And if it requires using tests that are inexpensive but can be used frequently to be sure that you actually find somebody during a period of transmissibility, that would probably be much better. It's not just sensitivity, speed matters. Speed matters as much or potentially more. This is a simple thought experiment, but one that is actually very realistic to what's happening today. If we have two on the top and bottom here, we have two identical sets of identical schools, and in each school, or it could be office or just out in the community, you have 5 individuals who are infectious walking into that school on the first day. On the top, you get you use 100% sensitive PCR test, but the samples have to get shipped out to a lab, so they take 2 days to return. Those 5 individuals who are infectious and walking into a school, while they might get 100% sensitive PCR test applied to them, there will be 10 person days walking around that school before they get detected as positive and pulled out of the community. So those 10 person days walking around might lead to an additional 5 or 8 new infections. And it will probably lead to around 20 or 20 plus quarantined individuals, which is on average, we generally see somewhere around 5 to 8 individuals get quarantined per infectious person. On the other hand, if you have an 80% sensitive test, which is often in the media these days and by physicians and others derided as not sufficiently sensitive. But if you have an 80% sensitive test that is fast and that's rapid, and those same 5 children or adults go into that school, 4 of them will be pulled out of circulation immediately. 1 will get by because it's only 80%, so the 20% go through. You ultimately have 2 person days walking around school infecting other people. So maybe you end up getting 1 or 2 additional infections and 5 or 8 people might get quarantined. But ultimately, if it's an inexpensive rapid test, you do it again. And so on day 3, you test again and you get and you detect that person. And ultimately, this obviously is keeping R far below 1 in this particular setting. So this is a lower sensitivity test, but it is the speed here that matters more than anything else. The moment you have to send a sample off to a laboratory, you're guaranteeing that anyone who's infectious is going to have at least 1 or 2 or 3, or in the United States, sometimes 7 or 10 days walking around before they get a result, meaning that effectively, you're not going to be able to use testing to effectively isolate individuals. We've used various mathematical models to explore this in more detail. And essentially what we have here, what I'm showing, are agent-based models. We incorporate viral load dynamics, similar to the trajectory I showed just a moment ago, into the agents. And we ask, what is more important? Is it the sensitivity of the test, or is it the frequency of the test that is going to be required to actually be able to pull people who are infectious out of the population and prevent outbreaks from continuing? What we find is that the sensitivity, not surprisingly, has almost no bearing on the ability to stop infections from transmitting. And that's again because the difference in this case is the pink is a PCR quality test and the purple is a rapid antigen test, 100 times less sensitive in this case. What we find is that that 100x loss in analytical sensitivity is truly inconsequential for the most part. And that's again because the period of time when it might be important is at the beginning. And at the beginning, again, the period of time that somebody is going to be positive on the higher sensitivity test is on the order of hours before they turn positive on the second rapid test. So what is much more important, which this graph is meant to convey, is that it is the frequency of testing that is so much more important. The moment you start to get to testing weekly or testing every 2 weeks in the population, you're just unlikely to find people during that period of time. And this is testing most of the population every 2 weeks. In general, I think that would be asking a lot. Most of the United States population has never been tested. We have thus far performed around 350 million tests in the US. That's enough for about 1 test per person over the last year. So we do not have a frequent testing approach. And in fact, I would say, given a testing approach where we've had on average 1 test per person in the US since this pandemic started, suggests that we have been woefully inadequate in detecting actual cases overall, not even beginning to come close to approaching testing every 2 weeks, no less every 3 days. But a test like these rapid paper strip tests actually has the potential to enable us to truly test at home in the privacy of our home. Brush your teeth and you take a rapid test, and you could do that twice a week or once a week, or potentially even every day if desired. And this is to show the same results, but given differences in turnaround time, which I gave the thought experiment for before. But the moment you have even a weekly test, if your turnaround time moves from 0, which is a rapid test, 15 minutes or so you could do it before work, for example. If it becomes a 2-day turnaround time, then in both of these bins, essentially, if you have weekly testing with a 2-day turnaround time, you essentially lose almost all of the benefit of population scale testing. So and in the US, 2 days is pretty fast, frankly. And so most of the testing that we're doing, if it is meant for public health, it is failing, unfortunately. And we continue to push and beat the drum of PCR testing in a laboratory despite this type of evidence. And so how could this be used at a population level? If we take an outbreak, or if we take an epidemic, and this is again simulation modeling, but we start with a very high prevalence, in this case 4%. So we have fast, rapid growth of the outbreak, and then we start testing people on a regular basis. If we had these rapid tests out in place, and we had 50% totally refused to listen to the results or pay attention to it, but 50% did and used them twice a week around, and including 10% failures of the test, we would be able to potentially get enough people to identify that they themselves are infectious early enough in their infection to be able to isolate and ideally stop transmission from moving forward. So the assumption here is that of those, in this case, 40% or so people who are properly using the test, they would have some way to isolate. The important thing is we have, people often suggest, well, we need to be able to pay people to be able to isolate so that they don't have to go to work. Absolutely, absolutely essential to be able to get those pieces in. But nevertheless, work isn't everything. School, going to see family, and everything else is a part of the transmission chains that we have. And so just knowing that you're able to isolate, just knowing that you're infectious can go a very far distance to helping curb the spread of infection. And importantly, while we have suggested that 10 days is the needed time, if everyone has these tests available to them at home while they're isolating, then maybe we can shorten that isolation period to 4 or 5 days for most people. And we could start to create policy that says you can go back to work once your test is negative for 2 days, because you'll have the test. You don't have to use a conservative window of 10 days, which is exactly that, a conservative window. We could greatly reduce the period of time that people need to isolate, making all of this much more palatable. So while our priority has been sensitivity first and foremost, our modeling and common sense suggests that frequency and speed are much, much more important than sensitivity if you just include the kinetics of the virus into your thinking, which unfortunately we don't have a regulatory landscape that's capable of doing without thinking about a public health pathway to evaluate a test. So I just went through all of this, but do simple, inexpensive rapid tests like this work? We just completed a large trial at a college in New England. And what I'm showing here, what we did was we took individuals who were in quarantine, who may have been exposed, and we started testing them daily or near daily with PCR. So we were able to identify individuals the moment that they became, the moment that they converted to PCR positivity, we had an antigen test run at the same time. And so some of them we didn't get exactly 1 day before, but in general, we were able to find most people who were recently negative on the PCR, and we were able to identify them. what we found was, of course, on day 0, we only had around a 30% sensitivity. And again, that's that blue section that I spoke about, which you can see on the top left, when PCR is positive, but the lower sensitivity test is negative. But then very quickly, the positive percent agreement between the rapid test and the PCR moves up to 100%. And it stays there for 2 to 4 days or so. On day 4, that was actually just somebody with a very, very low CT value of 40, high CT value, low viral load of 40 who we missed. But in general, then you see this linear decay. That decay between days 5 through 10 isn't a problem with this test. The decay is due to people clearing the virus, as you can see on the top right here. People clear this virus very, very fast. And so those are people who we maybe don't need to identify anymore. If we're doing frequent testing, twice weekly testing, our results suggest that we would catch nearly 100% of people at some point during their infection. So the tests do work, and this is the test that the UK has primarily been using. We can ask this question in a more elegant fashion using a mathematical model. The FDA requires that these tests have an 80% sensitivity against the PCR test. And so this is why we don't all have these tests available to us today. The FDA is currently regulating that a test like this must achieve 80% sensitivity in asymptomatic people to get a claim, to get an over-the-counter non-prescription use claim that would be required for this sort of daily or twice-week testing. But the requirement from the FDA for 80% sensitivity is essentially a mathematical impossibility. What we're showing here is an SEIR model, and it's a very simple model. It doesn't even take into account viral load. It is just asking the question, if you are infectious for 10 days, which is a very conservative estimate, you're probably infectious for more like 6 or 7, but if you're infectious for 10 days and the PCR, which is being considered the gold standard comparator, is positive for an additional 5, 10, or 15 days after that, what would be the measured sensitivity against the PCR of these tests for a company trying to get these authorized doing the studies? What we see is that depending on where you are in the course of the epidemic, the sensitivity is going to change. I won't go into detail about why that is now. But the important thing is that in no scenario, essentially, do we see amongst asymptomatic people that are pulling off the street and testing these tests against PCR, do we see a sensitivity that is exceeding 80%? In fact, the most likely scenario is probably something akin to the middle line here. So the expectation is around a 60% sensitivity to around a 35% sensitivity of this test against the PCR, which is exactly what we often see. And there's been a lot of media reports and papers that get it wrong, and they say these tests don't work. They only have a 35 or 40 or 50% sensitivity compared to the PCR. But what we've shown is that if your goal is to identify infectious individuals, then that might be a perfect test for infectiousness, even if it's only displaying a 35 or 40% agreement with the PCR. So this is the type of thinking that I would like to see the FDA start being able to incorporate. And frankly, the CDC and others are just missing this point, which is quite simple, I think. But we have yet to incorporate this type of thinking into our public health testing policies. We saw an example of this in Massachusetts when we did surveillance testing back in the summer. If we look at the CT values, the cycle thresholds of individuals who were positive during June and July, and each one of these is 1 week bin in June and July in Massachusetts, what we can see is that the vast majority of cycle thresholds were above 30. Most of them, 50%, were above 35. All of these people ended up getting isolated because they were deemed to be infected and needing to be isolated at the moment. Probably very, very, very few, if any of those people, 50% above 35, were actually infectious. Most were post-infection. We simply missed them. So the use of the PCR test is likely too sensitive and causing erroneous isolations and quarantines versus having a test that's actually identifying people we truly want to identify. So for the future, you know, I think we're seeing vaccines rolled out, and so this slide is now a bit outdated, but I think we still really want to think about how testing can be used to curb spread, to curb outbreaks. My expectation is we will see surges in cases again in the fall. I think seasonality is on our side between now and then, but we'll probably see surges, and we will probably wish we had frequent availability to testing probably come this fall. And I hope that we can find our way from a regulatory landscape to see these tests become available. And this is my last slide, which is to just suggest that while we have used extremely sensitive tests throughout this pandemic, these PCR tests, they might be 100% sensitive to catch virus when it is there, probably not quite 100%. For what really matters from a public health perspective is, are you catching people in time to act? And are you catching the right people? And despite being a very, very, very sensitive test, we probably have around a 5% sensitivity to actually detect cases that are infecting other people. And this is this demonstrates a severe gap between medical testing and public health testing that we still have not really worked our way around. So with that, I'm going to conclude. Some of the contributors who have helped thinking through this and doing a lot of the mathematics are on the left here, and thank you.
Michael, thank you very, very much. Very clear message, I would think. It's my great pleasure to give the floor to David Hunter. David is a Richard Doll Professor of Epidemiology and Medicine in Oxford, but also a Professor Emeritus in our institution here in Boston. Dr. Hunter, please.
Good, thank you. And now I'm going to share my screen.
Yep.
Terrific. So thank you, Michael, and thank you, Bert. And I think actually we owe Michael a real debt of gratitude for keeping this issue in front of both regulators and the public, and also providing the conceptual and quantitative basis for the use of rapid tests. And he hit the nail right on the head with his title, because this turns out to be, as much as we would like to think of it as an issue of test performance in the way we classically teach it, it's as much an issue of public policy, public health, and regulation. And he said that there's been more use of lateral flow tests in the UK. That's true, but it has not been a simple story. And Tim Peto will talk about some of the data that's been put together on the use of the tests. In the Nuffield Department of Population Health, Phil Clark, quite early on, pointed out that we could go back to an old idea that sort of comes back every time there's a need for large-scale testing, which is the idea of group testing or pooling tests when you have a low prevalence of a positivity and maybe an expensive or difficult to access test, and putting people in pools of 10 and then just retesting the people who are in the positive pools. That's actually something that has been used. It's been used at University of Cambridge. Some of the universities in the US have used it, and it is a strategy to cut costs and make wider availability of a test, particularly if it's a PCR test and relatively expensive. And then Julian Peto and others really tried to flag up this issue sort of early and often. Here's a list of letters and commentaries. And very little traction. In the UK, the decision was early on to run testing through the National Health Service. There were limited numbers of tests. They needed to be prioritized for people who had a potential clinical case and staff. And then an organization called Test and Trace, which was highly, highly centralized in a small number, about 7 now, mega labs, and samples were moved sometimes literally hundreds of miles to the mega labs. There've been a lot of problems with exactly the issue that Michael Turns talked to, that If you're moving samples a long distance, then you've got the time of the test. You're going to have 2-day, 3-day turnaround, and that is going to miss the window of opportunity to identify people at the most infectious stage. After lateral flow devices came along, there's actually been a lot of use of those. And again, I'm sure Tim will talk about those. But there's been a really big backlash. And initially, from the epidemiologic community, the complaint was, well, this was sort of August, September in the UK, when actually prevalence was fairly low. And the complaint was, well, you'll, in a low prevalence setting, even with a high specificity, your predictive value positive might be 50%. And so you'll be asking for each person who should isolate, you'll be asking another person who is negative and doesn't need to isolate. Unfortunately, when the epidemic sort of took off so fast in October and November, that predictive positive value argument ceased to exist because the number of people who were positive became so high. So then the criticism turned to low sensitivity, or quote, low sensitivity. And so if your sensitivity in real life, and then there's another sort of set of data that suggests that use of the lateral flow assays, if someone has minimum training, is less sensitive than if someone has a higher level of training, that you'll be missing too many people and you'll be giving too many people a false sense of reassurance. They'll be walking around infecting people. As Michael's pointed out, it completely misses the point that anybody who's positive, potentially infectious, and if you successfully isolate, that is a win. But there's been a whole raft of program performance characteristics from the very highest levels. So in their enthusiasm in July, August, the government announced a moonshot to test everybody frequently, even before the tests were at hand. And that sort of exploded on the launch pad because it exposed essentially the government to a certain amount of ridicule. And it also unfortunately enabled some of the people that were critical of the program because of test performance to critique it on the basis of it's essentially a fantasy. One thing the government did right, though, was to commission people like Tim Peto to actually test the tests. And rather than having, as I understand it in the US, testing companies doing the tests, going to the FDA with their data, there's been much more of a centralized effort to do routine analysis of the performance of the tests. In Liverpool, the army was sent in to help with test distribution. Sort of never a good look when you're sending in the army. The uptake there was lower in more deprived areas. As Michael pointed out, it's critical that people are incentivized to isolate if they're positive. And in the UK, we've had inadequate financial support for that. Even when someone's positive, some of the data on self-isolation is pretty dismal, perhaps because of the lack of financial support, but also other issues of social stigma, suppression of testing, lack of rapid confirmatory PCR testing, and most of all, this very centralized system, which didn't have a good interface with local public health. Current plans, schools are going to open up in October. There's still a plan that school children will be tested twice a week using lateral flow assays. There's a bit of an argument about whether parents are going to do that or what age are the kids old enough to do it. The teachers certainly don't want to be responsible for this. Workplace frequent testing is taking off. Door-to-door testing when you need to saturate an area is taking off. And there's still this ongoing discussion about whether it would be even legal and ethical to test for admission to mass gatherings. Just to finish, I thought it'd be good to sort of compare the Harvard University with the Oxford University approach to testing. So at Harvard, very early on, repurposing of a major lab, the Broad Institute, to provide rapid PCR testing, not just for Harvard, but for other colleges, universities, and the whole state. If you want to be on campus, testing 2 to 3 times a week. University administration, very, very pro-testing. Still, work from home if possible, distance learning for people who aren't on campus, don't need to be on campus. All of this is PCR based. The assumption going into this was it'll work, let's do it. And I think it's fair to say that there have been minimum outbreaks. Oxford, sort of interesting, over the summer, very little support for setting up an independent capacity. And a lot of that was because of the feeling that Oxford shouldn't do something the NHS, National Health Service, couldn't provide. But there's also skepticism about the value of asymptomatic testing. We did provide PCR testing for symptomatic people through the NHS. University administration was pretty adamantly anti-testing, but we're still doing some of the same things, work from home if possible. Now, lateral flow assays are being used for some undergraduates and schools, and actually the Nuffield Department of Population Health is the flagship department that's testing this. But things didn't go well, even with the students. So there was an idea that the government pushed that everybody before they went home for Christmas should have a lateral flow test, so they didn't take the virus back to their homes. Only about 50% of students even picked up a test, and only 50% of those returned a test. So the ability to get these programs running is complex. And the data at the end of the day, there were several outbreaks. They were college-based. They were picked up due to symptomatic testing, and then they were suppressed due to local lockdowns. So Oxford would tell you that symptomatic testing has been okay. Nobody was hospitalized. Nobody died. There's no evidence of staff transmission to staff. Harvard would, of course, tell you that because of the asymptomatic testing, we've kept Harvard substantially COVID-free. So just a note about the complexity of converting this to the real world and the difficulty of taking any single program and reaching larger conclusions. So with that, I'll hand it back to Bert.
Thank you, David. Thank you very much. Also in the hope context, this comparison of Oxford and Harvard is very, very helpful, I think. I think for time reasons, we will immediately go to our next contribution. And it's great that we have Dr. Tim Peto, Professor of Medicine and co-leader for the infection theme of the Oxford Biomedical Research Center in the Nuffield Department of Medicine. Tim, it's wonderful to have you. And you have asked me, I tell the people who listen, you've asked me to warn you when you still have 5 minutes to go.
Yeah,
and I will do that. Please.
Okay, thank you very much for asking me to come and talk about this. I'm a infectious diseases physician by background. I'm not related to Julian Peto, who's been mentioned before. And the government is promoting mass testing to reduce transmission and support early release and lockdown. And the main controversy, I think, is how to interpret a negative test and what to do with it. That's what the country is challenged by. Now, as a background, I totally agree with what Michael's been saying. We want to try to identify infectious individuals, and we really ought to simply remind ourselves of how we do it at the moment. But at the moment, we are doing it epidemiologically. Have you been in contact with somebody? Have you come back from a foreign country? It doesn't matter what foreign country it is. Any foreign country is obviously very dangerous. Even if England's got the biggest outbreak in the world, other countries are dangerous. And doing that, you don't pick up very many people who are positive. Most people are positive without us picking them up. And also the people you point the finger at are probably not positive. The other thing you can do is to get the fever charts. You get these fever machines looking for fevers or other symptoms. And again, we know perfectly well they're very poor at picking up people who are positive. And just remind ourselves that we have not got a method of picking up infectious people, although we use these things to lock you up and quarantine you. Otherwise, laboratory methods, although Michael talked about PCR being useless for picking up infectiousness, I won't go over that, but essentially, most people can't get PCRs, so it isn't a very good way of picking up infectious people, and if it's positive, as Michael said, half of them or more are not actually infectious. I won't go around that. I won't pursue that argument anymore. If, however, you have hot symptoms, cough, fever, breathlessness, and a positive PCR, that's a pretty good predictive value of being infectious, but very few people fall into that category. Now, the other thing I want to put back, remind you of, is the current methods of controlling COVID. We've got universal precautions, social distancing, face masks, hand washing, avoiding skin-to-skin contact. That's standard practice around the world. And then we have this business about quarantine individuals at high risk of being infectious. And we've got this guilty by association that if you live in the wrong part of the world or been in contact with people, you get locked into quarantine. And I've got here a sort of medical model of quarantine days to avoid the transmission. They're slightly guesstimates, but order of magnitude ideas that if you just lock down in a region with high prevalence, like we do in England now, probably 1,000 people a day to prevent one transmission. And the contacts are not very efficient. Most people who are quarantined after contact are not infectious. And people know that, which is why they're pretty fed up with being asked to quarantine. And I've got other pictures, even if you are a known PCR, if you're PCR positive, you're probably not infectious, as Michael said. You've got to probably have 20 to quarantine days to avoid the transmission. And lateral flow tests give us the promise of a much more honed in specific test for truly infectious people. And that's the great promise of this. Background, we've now got all 1 million NHS workers were given boxes 25 to take home for twice weekly testing. So far, we've got 44,000 people, healthcare workers who would otherwise not have been detected and went to self-isolation because they tested themselves. And it's widely available now. It's being rolled out more and more and more. As many lateral flow tests are done as PCR tests now. And most of them are what we call semi-supervised testing. That means that when you do the test, you might do it at home or you might not. But the important thing is you've got someone to tell the result to. You've got someone to turn to with your result who can help you decide what to do with the result. And that we find that is quite a helpful starting point. It's not like members of the public go to the street pharmacist, pick up do it on their own without any help and support for a positive test. And another 30,000 or so have been picked up so far in that way. And there are quite a few reports, increasing reports and studies showing that these are very popular. People like having them. They give you reassurance for lots of different reasons. And certainly amongst the healthcare workers, these are clerical officers, not necessarily, or cleaning people, not necessarily doctors or nurses. They find it really, really comforting to be able to test yourself when you're anxious about being positive. In case you haven't seen them, this is an example of one person. Michael really talked about this. This is one person doing daily testing, healthcare worker. They were feeling a bit ill, slightly ill, fatigue, and the PCR was positive. I haven't got the CT value because they don't give you a CT value, and the tests were negative. And the next day, they were also negative, but by day 2 of the illness, they became weakly positive at 5 minutes. That's a band intensity. And then days 3, 4, by day 4, it was a strong band, instantly positive. There's the fever chart. And then you can see day 5, 6, 7, it gets fainter, and by 9, it's only just visible at 30 minutes, and by 10, it's gone negative. Interestingly, it's exactly the same. There's one particular person who could do it, but it's exactly the same results as Michael's put up just now in his study. So the last bit of the sort of soft bit of this talk is how should we use these things to control transmission? And this isn't a modeling statement. This is a sort of a holistic view. If you have, at the moment we have in this country, in the UK, we have symptomatic testing, which is voluntary. But when you get, if you're positive and you name somebody, if you're symptomatic, you have compulsory quarantine. And more importantly, if you name somebody who is a contact, they have compulsory quarantine as well. The scenario which is being rolled out is rapid testing of asymptomatics and with compulsory quarantine of their contacts. The issue about that is that that's increased accessibility, but because people are reluctant to ping their friends and get them quarantined, there is a limit, there is a reluctance by people to do mass tests, to test themselves if a positive test means that you ruin the life of your friends. And we see that over and over again. And so the alternative, scenario 3, is not acceptable. I'm not promoting it, but were you to have rapid testing without any quarantine, forget about quarantine, just look for the positives, we would expect to get a far bigger uptake, and you might end up with a better position than scenarios 1 or 2. However, there's a middle way, and the middle way is that you take your mass testing, and when you get your contacts, rather than having, when you ping them, rather than having compulsory quarantine, you do DCT, daily contact testing. Every day you test them, and whilst they're negative, they're allowed to live normally. That is the hope, that you can have a win-win. You increase mass testing to pick up the positives, and you don't quarantine the negatives. And that is currently under evaluation, and that is the thing, the policy that is causing a lot of controversy around the country. A lot of controversy, heated arguments. So before we go back to that, what's the evidence we have that lateral flow tests are good enough to detect infectiousness? Well, we've heard, and I'll give you some more evidence on that. It detects medium high viral loads. Is that good enough? And Michael gave a lot of sort of theoretical reasons why that is the case. There's no laboratory reference standard for infectiousness. You can do viral culture on small numbers, but frankly, we don't even know whether viral culture tells you how infectious somebody is, because we don't know what the cutoff is. And the other thing is, so what we do expect is that quantitative viral loads are related to infectiousness. And we also know that lateral flow tests are good at detecting high viral loads. So what we've done is we've used the quantitative PCR results of PCR machines as a exploit that under the bonnet result to link the infectiousness with the lateral flow test performance. I should note that these qPCR machines haven't been well calibrated. And one of the big technical challenges we've had is to compare what we call CT values, cycle thresholds, with viral loads between different laboratories and labs and machines. And that is a sadness. And if we could have a better system for that, it would be very helpful. HIV viral loads have been done very nicely quantitatively now, so it can be done, but it's a bit of effort. And we've used the results of contact tracing, using it as a bioassay for infectiousness. So we aren't using a laboratory to test infectiousness, we're using a bioassay of other people. I'll come to that. So how good is lateral flow test against viral loads? And we've talked about this before, you probably know this. We've got panels of samples against freezer samples, we do field testing. And most of the field tests are symptomatic, but actually some are asymptomatic, and there's no difference in the answers. This is not a big difference. And we've got the large Liverpool study, which has now been available publicly. And I could say that all the tests we've used have got good specificity. They're probably less than 1 in 1,000 false positives. The more we do, the better the specificity. Less than the 1 in 1,000. This gives you an idea of the sensitivity of INOVA result. We've got here, the black line here tells us what proportion of results are positive according to viral load. That's 10,000 to 100,000, and you get about 90%. And over 100,000 is about 95% in this study. And that gives you how many we did. So there were a number of individuals, and that you can see the how many were positive, how many were negative. And I'll come back to that. But the 10 to the 4, 10 to the 5 number is really quite an important thing to remember. We've also got this idea of what proportion are positive. Now, the proportion positive in this study depends on the mix of people that you're looking at. So the proportion positive of our group of positive patients how much that lateral flow test does is really not very helpful because it depends on the proportion, how much viral load there is, the distribution of viral loads in that group. And that is often not described properly. This is field testing. So we've now compared different studies. I've got here one field testing, test and trace, where they had people mainly symptomatic, but some asymptomatic ones. Then the Liverpool study, we got Manchester, York, and then we had the ones the first study, healthcare workers and our scientists doing the first field evaluations, where they thought were probably better at using the tests. When they've got high viral loads, there's 1 million, 7 to 10 million, they all do quite well. And then really the difference occurs in the mid-range. And at low viral loads, nobody does it properly. I mean, not properly, the test is not designed to pick up low viral loads, 0 to 3 million, 3 to 4 million. What's interesting because a lot of fuss about the fact that the Liverpool study didn't do so good, as we did at the healthcare worker lot we first did in our first evaluation, was that when they reviewed the photographs of 6,000 cases and reclassified the results, it was quite clear that there were quite a few people who entered the results wrong, and there were clear positives on the photograph, which the individual took. So it was a very trivial reading issue. And then we also discovered that when they reclassified, there was a better performance. It went up from 70% to 85% in the ones above 10,000. The other thing which was very interesting was that the actual error rate reduced over time. So this was an early training problem. And I think one of the challenges about this is you've got to work out how good the training manuals and training documents are and videos as to how to use them. I think it's like asking novices to do what we call in England a soft-boiled egg with a runny yolk and hard white. I mean, it's very easy to do, but equally very easy to do wrong. And you must remember to boil the water before you put the egg in. And you've got to wait 5 minutes, not 3 or 10. So those are mistakes you can make. And I think lateral flow tests are easy once you've done 1 or 2. Now, then the next bit is, what's the relationship between viral load and infectiousness? Well, it's biologically likely. But what we did was we went and did direct measurements of contact data. Now we've got this big test and trace data system, which David Hunter was very rude about because it's centralized. We've managed to exploit this centralized system because every time you go for a PCR test in these centers, you ping your contacts, and they in turn can come up and get tested. And so what happens is if you ask to name the people who've been you've been in contact for 48 hours before your test, and then you have to self-isolate as a positive person, and the contacts in turn often go up for their own testing afterwards. And we can link that, and we have linked that, and from that we can work out how many people are infectious. And the paper we've written, which is it's still under review, but that's the website where you can get the posted copy done. Just to give you some idea, in this first pass, we had 700,000 cases, which we followed. And I won't go through this in detail, and then we had, of the 700,000, we had 720,000 contacts, which were actually on the database. And in the end, we restricted our follow-up down here to people where the contacts came with the test within days 2 to 7 of the index case. The idea was to try to reduce the number of people who were unlikely to have been infected by the index case. So we ended up with 57,000 contacts from 40,000 cases. And the 57,000 contacts were the ones who turned up to the test center for PCR tests within 2 days, 2 to 7 of the index cases PCR. And we excluded people who were care homes, universities, because they're living in complicated structures where you don't necessarily have an index case giving it to the victim. We did standard statistics of multivariate logistic regression to investigate the association between PCR confirmed infection and contacts with a CT value, the viral load, in the potential source case. We also had information about the nature of the contact, the cases demography, and social deprivation indexes and postcode and things, looking at the prevalence of disease in that area. We did some normal backward elimination. I won't go into that too much. And we screened for pairways interruptions. So in the end, we had 19,000 positives, PCT positive patients. And not surprisingly, the viral load, the CT value, was very important in determining PCR results. And it was about, CT was about 0.93 reduction per CT value, or the odd ratio. Actually, that's a reduction, I'm sorry, a 0.80% chance of getting infected for every tenfold decrease in viral load. It's the wrong way around, decrease. There's always a problem that CTs are going in the wrong direction from viral load. And importantly, although lots of the other factors, like being in a household, I'll show you this data, affects the overall infectiousness, that relationship between viral load and infectiousness was not, there was no interaction with any other factors we had in terms of the slope of that curve. And I'll show that to you. So this one is not a viral load picture, but I'm putting it up because it's interesting to my mind. This is the effect of age on infectivity. This is household contacts in red. In green, we've got a household visitor, and you see this lovely increase in the infectivity for people, young adults visiting households. I wonder what they do when they get there. It's not for me to say. And then we've got outside household activities, which is purple, and then we've got work activities. Now, this group down here, under 20s, these are basically school children. And you can see school children at the age of 10, 15 are less infectious to their friends at school compared to their household contacts. And that is quite an interesting extra piece of information we've got. Now, the important thing here is the effect of viral load. And of course, this is the wrong way around, because 10 CTs is a high viral load and 35 is a low viral load. And for the different sorts of contacts, household, household visitor, and outside the household, we're seeing the same slope, and you're seeing a good effect on viral load. There is an interesting issue about whether or not this is really as infectious at 35, very low viral loads, as we see, because we don't actually talk about third-party transmissions. We couldn't adjust for that on this particular first attempt to do the work. And then what we did, we got that result, and then we could look at the performance, expected performance of lateral flow tests and picking out those transmission events. We actually now recently extended this to 170,000 index contact transmission pairs because we've got a bigger data set. So just to remind you again, this is the overall sensitivity in CT values, that's the viral load, which we get from Inova. So if you're running at 25, about 6,000, you pick up about half positive. And if you are on very low numbers, these are the actual numbers of particles per mil. So 30 to 150 RNA copies per mil in the solution. It's really not very many. It's not surprising you don't pick it up on the lateral flow test. And we apply that. Now, this is a complicated graph, and I'll just take you through it. If you look at this line, this tells you the CT, the viral load of the people, of the transmitters, cumulatively. So if you look at 50% here, about 50% of the people transmitting are over 1 million. So if you imagine going to your ball game where lots of people are positive, and you come back and you get the disease from all these positive people in the ball game, you've got a 50% chance of getting it from the people above 1 million. If you go to above 100,000, it's about a third, 2/3 above 100,000. This is the distribution. This line is the distribution of the viral loads of those 160,000 people who are transmitting. That's just the cumulative curve of that, so you can see it. Now, what does lateral flow pick up? Well, it picks the reds up, but the blacks are the what they miss. And they're missing the low viral loads. And the important debate is whether these people are actually as infectious as our test and trace data suggests, or whether in fact we've overcalled it. And in this particular case, 85%, the blacks is 85% of the total. Now we've gone on to look at 18 tests.
Tim, this is your 5-minute warning.
Thank you. Thank you very much. 15, done 18 tests, all the good, different manufacturers. And these are the 18 sigmoid curves. The red one is in over twice, so you can compare. And what you should note is that there's sensitivity changes, you go from left to right. But actually the shape changes. That's like the affinity changes. So if the monoclonal antibody, which is bound to your blotting paper, is got a good affinity, you have a very stark curve. And if it's like that one, it's probably poor affinity. So there are characteristics, you can't have one number describing that curve. And I'm showing it to you because FDA wants to have one number. And I'm saying we can't have one number, we have to have two at least. That's just a minor point, but I think it's quite interesting. Now we apply it. So this is, we're taking the 200 samples out. We go back to 200 samples and we say for the different tests, what proportion of those samples which are positive with a variety of PCRs, viral loads, the lateral flow test comes up positive. This is what the cynics in England get cross about. This is what probably FDA get cross about. The Innova in this particular population only picked up 55% of the positives. That's because of the mix of people. But if you then use it to work out that property, how much of the infections did you pick up using our 17,000 target cases, then we've got there 85% or thereabouts. And these are the scatter from the different kits. And then I've done another picture, which is if you want confidence intervals. And this time, instead of looking at the rather hopeless way of looking at all the percentage positive depending on the mix of people, I've used that sigmoid curve to estimate the actual sensitivity at 100,000 RNA copies per mil. And I then apply it to the data, you get that relationship. And the reason why it's going from there to there is because of that shape changes, or that curve, the slope is different. There's Innova for comparison. I haven't named the kits because I need UK government. I think it'll be posted on the website, I hope, within the next few days. We sent it to them for publication, but they make their own decisions about what names we can publish. So I hope it'll be out very quickly. So you can see that most of them do quite well. That one's a nice one. And that one, I'm calling it Kit C. That's the one I've just showed you. That's the picture I've shown you. I want to now show you what the picture for Kit C looks like, which is the best in the pack. And you can see it's gone down a bit. So that's the bad one. That's the good one, 90%. And you can see it's doing better. So what are the biases in our estimation? These are direct estimations. Well, I mentioned we haven't got third-party transmission. We haven't evaluated that. We've got a chance of doing this because we've got the Kent variant, the S deletion, and we can look at discordance in genomic discordances between so-called transmission pairs and try to get an idea of how much discordance there is. I can already tell you that there's more discordance in the low viral load people. So we certainly are seeing third-party transmission interfering at the low viral load. And then other things we haven't measured. And there's a time basis. I'm going to stop soon. So what's my conclusion? We think that lateral flow tests can detect 80–90% of transmissions, and that we think that it's pretty safe. Any leakage of infections by quarantine release is more than counterbalanced by the increase in voluntary testing. We want decent training modules. And the early suggestion is that people love it. They love these tests. And we're doing studies now to directly assess the secondary attack rate, particularly in schools. Okay.
Thank you very much, Dr. Pito. This very impressive study, by the way. Yes, I would like to go over now to Dr. Mark Lipsitch. Mark is the chief of the Center for Communicable Disease Dynamics in our Department of Epidemiology in the Harvard Chan School. And Mark, you've kindly agreed to be the discussant here of Dr. Pito. Go ahead.
Thank you, and thanks to Bert and others for the opportunity to be here. Thanks, Tim, for a really stimulating talk, and in particular, I do really recommend the paper that he cited. I found that I could not download it with Chrome and had to use Safari, so it took me a while, but it bears having a look. And also thank you, Tim, for explaining to me why I've had so many bad boiled eggs when I've come to England sometimes. I want to make a sort of technical point, which Tim began to make at the end, and then talk a little bit more about the big picture. The technical point is really to pick up on the issue of measurement error and the notion that the CT value at a single point in time is being used in that study as the datum that as a proxy for their viral load over the past of their infection when they would have been infecting people who later get contact traced. That means, for example, that if someone is detected late in their infection, they will have a lower viral load because the viruses will be coming down. They will look less infectious, but they will have had more time to infect other people than someone detected early in their infection who will have a higher viral load, making the likely relation, obscuring the likely relationship between infectiousness and detected infectiousness. So I think that may help to explain why the relationship was that having half as much virus made you only 0.7% less infectious, 0.93 times as infectious in this study. So this is not a criticism of the study, it's the best use of the data that's available, and I think very impressive that the relationship is detectable in that setting. But just for some context, of course, the theoretical expectation might be that half as much virus would make you half as infectious. Maybe not quite a linear relationship, but that's one possibility. And another study that was published in Eurosurveillance showed that that if you did viral culture at the same time as PCR, that the odds of viral culture positivity were 1/3 lower for every halving of viral load, every increase in CT value. So I think all of that is to say that I think that this relationship between CT value and infectiousness that's observed in this very nice study is probably a very conservative estimate, and that means that the proportion of infections detectable that you could prevent using these tests is actually higher, and that their estimates are conservative if this reasoning holds. So that's a technical point, but I think an important one that that I wanted to mention. I want to now really zoom out to make two other points about testing. The first is, and I think Michael mentioned something related to this very early on, and it was a theme about the sort of incentives for testing. Early on, people were more attentive perhaps than they have been recently to the issue of economics and the interaction with public health. So if you have paid sick leave, for example, then a person is much more likely to want to know their status because they are not going to suffer an economic penalty from mandatory stay at home without pay. If you don't have paid sick leave, that will discourage testing. And I think that that whole economic interaction, which in the US is complicated to some degree by the state versus federal distribution of roles, is something that I think modulates how effective testing programs can be, meaning a more supportive government and more supportive commercial policies make testing more effective. The other thing I wanted to do was to just briefly compare the situation with vaccines against that with tests. And I think there's an interesting comparison, at least on two axes. We are in an unfathomably good situation, at least in the rich countries, with respect to vaccines. There was, and that largely reflects investments that were made over the last 5 years in preparedness for pandemics through the establishment of CEPI, the Coalition for Epidemic Preparedness Innovations, through work at our US NIH and others to work on coronavirus vaccines and to work on platform technologies, including the two biggest ones of adenovirus and mRNA that have been successful so far. So there was a plan in place, a very foresightful plan, if I may say so, proposed in 2015 and implemented through CEPI. For diagnostics, there is no such thing. There is no comparable global effort to be prepared in diagnostics in the way that we are prepared in vaccines. And I think one of the really clear lessons of this pandemic is that delays in getting cheap, plentiful, accurate for their purpose tests are critical and really are part of the major explanation for why some countries have escaped the brunt of this pandemic and some have not. The second is, I think, a parallel of what Mike mentioned at the beginning, which is this issue of the public health approach versus the medical approach. Right now in the UK, there has been the decision to delay second doses of the vaccine. In the United States, there's been a discussion of it, but a very cautious, we must follow the randomized controlled trial view has prevailed, in contrast to that in the UK. And I think that is actually a case where a public health approach of trying to save the most lives, given all available evidence and weighing but not overly privileging data from randomized trials, is the approach in the UK. And I would say that the US has been in a more conservative, too carefully following the randomized evidence at the expense of other types of evidence posture. And I think that in some ways mirrors the approaches to testing. And so I think this rethinking of what the role of evidence and medicine and public health is may have applications in many sectors. And I must say that's a discussion that I have had in the past with Mike, and I credit him with some of my thinking on this as well. So I'll stop there.